All right. Well, hey everyone. Let me know if you can hear me. Hello, hello. See you all. Thank you for joining me on this Tuesday afternoon. Feels like it's been like a couple weeks since I talked to you guys, but it's Thursday, I think. Well, I'll get to see all of your bright and shiny faces tomorrow for the review that we had. Fine. There we go. All right. I already got a couple of questions to ask, so that's fantastic. We'll get started in a few minutes here. Of course, if you have questions, post them up in the chat or on the sticky board. Hey, Abby. I think we have a lab coming up in a couple of weeks, right? We'll be able to see you guys then. Oh, looks like it might be one. Fact. Fun. Hey, Kaylee. Also, if you guys can let me know, I have a tendency to like to play with my mic a little bit when it's in front of me. So if if you hear like any like noises coming through or something, just let me know and I'll try to stop it. It's probably a bad habit. But or any bad habits that I have, you can feel free to tell me all about them and I'll try to work on them. While bettering myself. Hey, Aaron. Got a nearly 1 minute ago. Some people may be running late. That's no problem. Although you should yell at Professor Kaplan for not being very economical with your time. Always tried to be good with your guys' time because I always hated it in school and I'd have professors that went over. I'm like, I got places to be, professor. Finish up. Yeah, there's no smackdowns. That is one good thing about our faculty is we all generally respect and like each other. Oh, thank you for that, Brian. I'm sure you'd be telling Professor Kaplan the same thing on the other side. If it was a duel of Star Wars knowledge, he might edge me out. It'll start about 2 minutes or so. Hey there, Peter. As time goes on, my kids get back from school. If you hear some screaming in the background, just that is par for the course. 41 of you guys, that's pretty good. 3 likes, oh, that's so sweet. Thank you all. I almost have 600 subscribers. That's pretty cool. I was not too many years ago that I was just reaching 100, so that's pretty cool. Even though I don't really post anything except these lectures, which I would not wish on anybody to watch out of like fun or something. That would not be great. But let's get started here. Let's my recording going here. I have a couple of questions I'm going to start with here. Oh, class announcement. This will be good. I'll probably try to post this up either as an announcement on the Canvas course or I'll perhaps mention it again tomorrow. So given the fact that we have about 58 slides left to go and then rheumatology itself, let me bring this bad boy up. That is also another 102. I was at a crossroads. I was trying to figure out how to manage this course to say like, well, do I try to run through all 102 slides real quick? That way it can all be on the test. Should I record extra videos and just make them watch it on their own time? I said, no, that sounds pretty mean spirited of me. So I said, I got plenty of time down the line. We'll be able to shift some stuff around. So that being said, for this first test, it's only going to be peds, GI, and the neurology section. So whatever we finish up today, which we should be able to with enough time, that's going to be the test. Okay. So that's a bit of trade-off. You say woohoo. However, there's a trade-off there, right? The trade-off being is that I have less material to test you on. However, I can get into more depth on that material. So some of you may think of this as sort of a mixed blessing, but we'll see how it goes. I think I ended up writing about 10 to 15 new questions. So we'll see how that goes. We'll see. I think some of them are pretty good though. So hopefully that'll be good. Anyway, so again, just I think they're the same level of, it's not necessarily the more difficult questions. It's just a matter of I have more questions to ask on these different varied things, so I think it'll work itself out pretty well. If Professor Sales reviewing it, so if she thinks that I'm being too mean, she'll probably tell me. She's pretty honest like that. So anyway, so getting into a few questions we have up here on the sticky board, and again, I appreciate the questions. Cheering turns to nervous sweating. That probably like half of the major events in my life. Anyway, so someone was asking about the prescription assignments and in real life too, I guess. Well, yeah, because these are supposed to be kind of true to life. Is there a true right or wrong medication to prescribe when there are multiple medication options, all with adverse effects and no contraindications for a particular patient? For example, in our assignment, would it be considered incorrect to prescribe Verapamil for migraine prophylaxis just because topiramate is becoming more of a first-line option? That's a great question. That is probably one of the biggest questions that you're going to have when going out there into clinicals. And until you really get sort of practice with it, it may not become really clear cut for you. Because it'd be nice if there was always like, okay, this is the go-to question. You should always do this. So, but that's not real life, right? So you may find that depending on the situation, like you can get some double duty out of some of these drugs here, right? So, and I apologize if I'm spinning too much, but I have a newer chair, so it's a little bit more spinny, and I have nervous habits. So anyway, so with like Verapamil, right, if you could treat two conditions at the same time with one drug, well, that sounds pretty good, right? So if someone had history of AFib and migraines, perhaps using the one drug for the both of those might be reasonable, right? But again, oftentimes as you're looking at the patient's means of even getting the drug, one, so like what kind of insurance do they have, looking at what kind of side effects the drug could be causing in conjunction with like what side effects they may already be experiencing from the drugs they're on, or drug interactions, or other concomitant conditions. So unfortunately, it becomes a very kind of complicated question. And honestly, you'll find that when you're working, depending on where you go work, so say for instance, you go work in neurology, you'll have kind of like your stable of drugs, right? We learn hundreds of drugs here in this class, but from a clinical standpoint, I think the average, I don't know if I've looked this up recently, but they say like the average practitioner's drug sort of arsenal is like 50 to 80 drugs or something, right? So you'll forget a ton of information from this class because you're going to know the ones that you use day in and day out. So you may have like, for migraine prophylaxis, I'm going to go with this drug 9 times out of 10, but for that every one time, I'm going to go ahead and go with this drug instead because of X, Y, and Z. And that's where the clinical, kind of the art, more so than the science of medicine kind of comes into play there, at least from my standpoint. Someone says, when writing prescriptions, is there a limit on how many refills a provider can write for? Does this depend on the type of medication? Can something that doesn't need constant monitoring, such as OCP or oral contraceptives, be written for a large amount of refills? Thanks, smiley face. Oh, well, thank you so much. I really appreciate that. You guys are so sweet. Anyway, it warms out the dark pit of my heart again. But anyway, so if you recall, we talked about this a bit back in the pharmacodynamics course, and we talked about how, in general, for non-controlled substances, you can do a full year's worth, right? So you could write for 90 days worth of a drug and have 3 refills, so you get the initial fill plus 3 refills. You could do it every month, so you could do the initial fill plus 11. You wouldn't want to write like 12 refills on a script because, that would make sense. It'd be like for the 13th month, right? So you always want to think about the original sheet of paper you're writing on, is that's the first fill, and then additional refills on top of that. So there's that. Remember, for controlled substances, there is a limitation on that. Remember, for C3 through 5, you're limited to 6 months. So say, for instance, I was writing for clonazepam for a patient for seizures. The most they could get would be 6 months at a time, because then the script would become expired, basically. So if I had someone who's on a good steady dose and I didn't really need to have them come in for any particular reason, you could write for all 6 months worth, right? So the initial fill plus 5 refills, basically. So you could do that. Remember, for C2s, there are no refills, okay? You could write up to 90 days worth. You could do that on 3 different scripts, doing 30 days, 30 days, 30 days. You'll see that a lot with ADHD medications, where a patient is on their Vyvanse and they're on a good dose of it and they don't need to come back to the provider. They only have to go in every 3 months potentially, right? There's that. And then but no refills on those. So that's kind of where you're at. If it's something where like people have been on it for years and they don't necessarily need to come back, and I think we had a script like this last semester. I think it was like a routine like lisinopril, HCTZ, and a ramipril or something. And it's like if you don't need to see them back until another year because they're really, blood pressure's under control, they're looking good, you can just go ahead and write for all 11 refills and you're fine. They don't have to see them for another year, right? So it just depends. That's where some of the clinical finesse sort of comes in. Someone said, in GI, we learned that Benadryl can be given with Reglan to reduce the side effects of Reglan. However, couldn't that increase the sedative effects since both drugs are known to cause sedation? Very good. Yes, this is true. We're going to talk about this a lot when we come into talking about behavioral health, when we get into antipsychotic drugs. So remember, when you're thinking about Parkinson's, what's the main problem? Well, you have a lack of dopamine, right? Remember, that lack of dopamine can increase acetylcholine activity. So that's why you get the tremor and stuff. And some of the other Parkinson-like side effects. So there's that disbalance between dopamine and acetylcholine in the CNS. So Reglan can do that too, right? Reglan's in a class of drugs that can cause a sort of Parkinson-like side effects. And we'll get into that much more detail in behavioral health, but basically these are called extrapyramidal side effects, EPS. I didn't get into it too much here because we were just talking about Parkinson's, but we'll talk about EPS a lot. And that's what Reglan can cause, extrapyramidal side effects. They're Parkinson-like symptoms, resting tremor, bradykinesia, things like that, right? So by giving an anticholinergic, just like we would for, say, a younger patient with Parkinson's who has just tremor, for instance, as their main sort of symptom, you could give them an anticholinergic to treat that. So you could do benztropine, you could do trihexyphenidyl, you could do diphenhydramine. Any of those are reasonable, right? In order to help to fix that imbalance between acetylcholine and dopamine, okay? So then to your question of, well, won't that cause extra sedation? Sure, it certainly could, right? And so that's something to where some people will develop tolerance to those effects over time. So maybe that sedation may be bad up front, but maybe after a couple of weeks, they're okay with that. Remember, Benadryl itself has some antiemetic activity additionally, right? So you could have someone who is particularly sensitive to the extrapyramidal effects of Reglan, and maybe you could use less Reglan. Maybe you could add on that Benadryl, and then the two are working a little synergistically, and then you're okay. Just really depends on how you're going to be using these drugs with one another. If I had someone, and this depends on the purpose, right? If I'm using Reglan as an antiemetic and they're having extrapyramidal side effects, instead of treating a side effect with more drugs, I'd probably want to switch them to something else. So if they're using it for an antiemetic, like do Zofran. Zofran's fine. You don't have to run into any of those issues. Non-sedating. If you're using for a prokinetic activity, maybe try erythromycin instead. Maybe that could be a good option, right? So again, this is why it's good to know what your options are, so you can say, well, if I'm in this situation, I'll try doing this instead, right? You always want a backup plan when dealing with these patients here. Someone said, for the assignments, are we graded more on the validity behind the details of the script versus the actual medication itself? I'm nervous because we are choosing the drugs ourselves, and there are so many options. Yes, that is on purpose. The idea is to sort of, last semester, you're sort of like in the kiddie pool, like I kind of told you all the drugs to give and everything. Now we're starting to like kind of sink down a little bit deeper into the pool. And now you got options, right? Now you got to be like, okay, well, what am I going to pick here? So if you pick something that is not indicated for that particular condition, then yeah, you'll probably get counted off on. But as long as it's like, it makes a sense and I can look at it and be like, okay, I see what you're going for, and this could be an option, then yeah, that's great, right? Because that's part of medicine. You have options available to you, and not everyone's going to be the right one for every single patient. So there's going to be some variety there, and it does make more work for me because then I have to look up the dosing for all these various drugs if I don't know them off the top of my head. But again, it gives you a little bit of that freedom. It kind of gives you your a little bit more of your body in the water, so to speak, before you just get dumped off the deep end in clinicals or something, right? You're not really in the deep end. You probably have like floaties on, but you get the analogy, hopefully. Okay. So I've done enough yapping about that. Let's finish up our PowerPoint here. Okay, so we're talking about MS. We were talking about kind of the pathophysiology of it, how it's, again, this immune response against the myelin sheath, essentially, of our nervous system, causing, kind of slowed conduction, causing a lot of pain, a lot of other issues, as we're going to see here. And the treatment for this, as you're going to see, this kind of will blend into rheumatology later on when we get into that. But you kind of go through these different phases. And again, this is very similar to many chronic conditions. You're going to have flare-ups. You're going to have exacerbations. There's going to be treatment to kind of manage the patient over the long term. Hopefully, if you can slow down progression of the disease, that's going to be great. And then managing the symptoms, right? So we kind of have similar sort of paradigms here as we would see for, say, for instance, asthma or for diabetes or, different things like that. So we'll talk about these different kind of modes of treatment here. Obviously, the biggest thing here is to, one, treat the quality of life, which is great, but also try to minimize that long-term disability, because this can be quite debilitating if not managed in a timely manner, right? So for those exacerbations, and this is going to apply to any sort of immune condition, hit them with the steroids, right? Steroids are always going to be sort of our most potent, relatively quick acting means of decreasing inflammation. And so that's what we're going to do here. A lot of times these patients may be getting, several weeks worth of therapy, or they may be on like, a routine dose every day for chronic management, and then you bump them up, right? And so that's what we can do for these flare-ups. If they're on oral treatment, outside of the hospital and they're coming in for admission for this exacerbation, switch them over to IV. That's typically what we're going to do there. IV is going to be a little bit faster acting, a little more potent. And then as they start to sort of stabilize, then you can switch them back over to oral treatment potentially. Usually we're going to see that for these flare-ups, the faster you can get therapy on board, the better. So if you can say, if they know they're going to have a flare-up, they know they're having an exacerbation, I'm going to get treatment early, because that tends to help out with some of the symptom onset there. It helps to kind of resolve the flare-up a little bit faster there, okay? Now, of course, just like we talked about the corticosteroids previously, we know there's a whole slew of different side effects. So things like worsened glycemic control. So we know blood sugars are going to go up because it's like you're stressing your body out with these extra steroids. But that diabetes, that's going to be more difficult to manage. Mood alterations too, right? Especially if in more elderly patients, you may find that they're getting a little bit more maybe snippy, a little bit more aggressive, maybe more depressed, right? It just depends on the patient, how they respond to it. And then actually what's really kind of wild too is that in some really severe cases, we can actually do a plasma exchange. So they've just like so many of these like inflammatory cytokines and antibodies and everything that's just causing all this inflammation. Like, we'll just get rid of them, right? So you can actually just pull all that plasma out and then exchange it for new stuff. And that has been used occasionally. And again, kind of outside of my purview to a certain degree, but pretty interesting too, right? And remember, anytime you're giving someone someone else's blood products, whether it be plasma, RBCs, platelets, anything like that, people can have reactions to that too, right? People can have allergic reactions to someone else's blood products. And so you want to think about things like, Benadryl for management of that, for the histamine release. You want to think about, again, they're already on corticosteroids, so you probably wouldn't have to mess with that. Or even epi is needed in some cases there. So recall what we talked about in the end of pulmonology in terms of managing allergic reactions, right? Okay, so this is kind of the cornerstone of therapy here, is what we call disease-modifying therapy, or DMT. And the goal here is to try and get this on board early, to try to either slow down or prevent progression of disease. Generally speaking, you're not going to see a lot of reversal of symptoms, which is unfortunately the case for a lot of like rheumatologic conditions and things like that. But if they can at least slow it down and prevent exacerbations, this is going to be helpful here, okay? You can see that they have some older school medications we'll talk about, and then some of the newer ones. This is where we're going to get into more of things like monoclonal antibodies used to help manage this, right? And so we'll see some of these second generation agents are going to be used for more kind of progressive or worsening MS, maybe not responding to the first line therapy. And keep in mind, especially with a lot of the first generation agents here, relatively slow acting. It does take some time. And you'll see this too in rheumatology, where a lot of these disease modifying therapies may take months to even years before you really note the true efficacy, right? So kind of some delayed gratification you might notice with that. And then a lot of these, especially the newer ones, tend to be quite expensive, right? $70,000 to $200,000 a year. Especially as newer agents come out, they're all on brand. They may be difficult to manufacture. Things get expensive, right? And so that's why making sure people have access to healthcare or have access to means of paying for that can be quite important here. Okay. So I'm not going to quiz you on prices necessarily, because I don't think that would be very useful for your purposes, but I do it to illustrate sort of the costs that can be incurred with some of these medical therapies. And this is like one drug of many they may be on top of things like going to the doctor's visits and if they get hospitalized and all these other things. So it can be quite really debilitating from a financial sense for some of these medications if they're not being covered appropriately here. Okay, so first drug I want to talk about here is interferon. There's a couple of varieties you may run into, beta 1b and 1a. Clinically, I'm not going to really get into too big of the difference between here. I just wanted to give you some examples of different ones we have available to us. You could just lump all these into interferon and you'd be fine from that standpoint. Now interferon is, a normal sort of product that we produce ourselves, and it is helpful to help basically suppress cellular function. It will help to decrease things like T cell proliferation. And the good thing with this is it does cross the blood-brain barrier, which is kind of where you need the drug to work, right? Because the inflammation is happening on the neurons themselves. We're going to see there's a lot of side effects with these as well, though. This is a protein-based product, so we're going to find that it has to be administered generally sub-Q or IV in some cases, IM, but parenteral therapy is required for these proteins. So that can be a bit of a challenge and may not be as palatable, so to speak, by the patient there. But just some different varieties here. Notice that there may be some varieties. If you ever hear pegylated, that is basically just a modification of the molecule in order to change basically some of the pharmacokinetics of the product. So as you notice here, interferon beta 1 or beta 1A, this is just Rebif 1 right here. Notice 3 times a week they're having to get it versus this one's every 14 days. So you can kind of extend out how long the drug's going to work for, which is, again, good from a compliance sort of standpoint here. Okay. So just note here that we're going to find that, and don't worry so much about pregnancy category. I'm not going to really quiz you on that necessarily. But some of the problems we're going to run into, including anaphylaxis. This is something you're definitely going to see. And not only just like anaphylaxis, but also sort of anaphylactoid-like reactions or flu-like symptoms you can experience with use of these medications. So you can get that kind of myalgias and fatigue and all of that. So this is not a great set of drugs, but it's been one we've used for quite a while. We'll see this as well when you talk about immunotherapy for hepatitis C, for instance. This is another kind of cornerstone therapy for that. Even some cases of leukemia, I've seen interferon used very rarely. So adverse effects, these are pretty nasty drugs in general, which is why it's good we have some of the newer ones available to us. But for some people who have failed other therapy, this might be what they require, basically. So you got to watch hepatic function. Certainly you can cause some hepatic injury here. Because they are suppressing the immune system, guess what? They can also suppress CBC, so that way you end up finding some risk for infection from that, right? So secondary infection risk does become a problem here. Flu-like symptoms, like I mentioned there. Anything you're injecting can have injection site reactions, right? Which could be just mild swelling, itching. It could be more severe in some cases. So make sure you tell patients when they're injecting drugs not to use the same exact location every time, but kind of rotate it around. So for instance, like they can rotate it around the abdomen instead of injecting the same exact point every time. They can find some scar tissue that'll develop and things like that. And the other big thing too to note here is these patients can have worsening depression. So this is a kind of a big black box warning, especially on the 1B ones, where you can certainly worsen their mood. There's cases of suicidality that have been linked to this. Keep in mind, people with MS, so that chronic condition, may be depressed already, and so you can see how that could certainly exacerbate that. You definitely want to be careful there. Okay, so now we have a few newer ones. We'll look at some different examples here. Here's one called gladomere. And so this is actually another protein-based product here. It's a polypeptide. Again, I don't care if you know specifically the peptide sequence here, but know that it's protein-based. And for, again, a lot of these drugs, we don't necessarily know the mechanism, but some of it's thought to basically act as sort of a sort of antigenic properties of one of these myelin basic proteins. It's thought to be the thing that actually causes a lot of your T cells to activate against the myelin sheath. And so the idea here would be to bind to that, sort of act as a replacement and basically prevent the activation of the T cells. Right, so it binds up the T cells so they can't then activate and work on our own myelin sheath. So kind of keeping it busy. So that's another way to sort of functionally antagonize those T cells there. And again, this is another one here. We're going to have a lot of injection related reactions here. So like 10% of people will develop like chest tightness and flushing and dyspnea. They may feel like they're having a heart attack in some cases, right? You can have some anxiety associated with that. Generally, you can, it should abate over time. They should sort of develop some tolerance to that, but it is one thing to just note there. And it can last for about 20 minutes or so. So it could be a very uncomfortable sort of thing patients are experiencing. And this is why for a lot of these protein-based products, you typically want to watch them in the office or in the clinic for 20, 30 minutes or so to make sure they're not going to have any problems with it. Because if they do have anaphylaxis or something with the first dose, then you want to be there to catch it, or if there are any of these other severe side effects. Here's another one. Here's a monoclonal antibody. You can tell because it ends with that MAB. It's called Natalizumab. Again, you can just call it Tysabri by the brand name. Those are generally easier to pronounce than the actual generic name, but I like to at least pronounce it so you've at least heard it once, but Natalizumab, and you get better with practice with this, so there's still something I have a hard time saying. This is one that is a humanized monoclonal antibody, right? Humanized meaning it's going to be mostly human protein, so a little bit less risk for things like, anaphylaxis than if it was more, murine protein or something like that, but it's basically an antibody directed at this protein called very late antigen 1 or VLA1. As opposed, I guess maybe there's a very early antigen. I don't really know, but this is a very late antigen. Side note, did you know that there's a protein in the body that's named after Sonic the Hedgehog? Look it up. True fact. But anyway, by having an antibody that binds to this VLA1, it's actually basically able to help prevent some of these, this seen as vascular cell adhesion. Basically, it prevents the lymphocytes from being able to cross the blood-brain barrier, right? So you're preventing immune cells from getting to the site of action where they would then have cause inflammation against the myelin sheath there. So again, another way we can try to either directly sort of antagonize the lymphocytes, or we could try to prevent their ability to basically get to the site of action for them. So that's one thing that's pretty interesting, another way for it to work. This one, if you recall, we talked about REMS programs in the past. For instance, like isotretinoin is probably the most notable one that we've talked about, but that stands for Risk Evaluation and Mitigation Strategy. So some drugs have such bad side effects that we have to put in these programs in place in order to look out for some of these issues here. Here's an example of one for natalizumab where you have to worry about this progressive multifocal leukoencephalopathy, something seen in some of the clinical trials, and it's severe enough that it's one of those things where you want to make sure patients are being monitored for it appropriately, make sure they're getting regular checks and things like that. This is not a type of drug you'd want to be prescribing for like a year's worth, right? You'd want them to be coming back so you can look for some of these issues here. Another case here, we can have mood alterations with this drug, fatigue, chills, things like that. And then secondary infections can happen. So for instance here, respiratory infections are a possibility, along with some hepatotoxicity, just to really make these just super great tolerated drugs, right? Just kidding, not great. However, if it is a trade-off between this and having progressive MS to the point where maybe they can't even like walk anymore, I'd probably choose the side effects of these drugs in some cases. Okay. Those are some of the older agents. Now we're going to get into some of the newer ones. So this one's pretty cool because all the other ones have been protein so far. Now we have Fengolamod, which sounds like something from like Lord of the Rings, maybe it's like Gollum's brother or cousin or something like that. But basically, this is the first oral disease-modifying therapy that we developed for MS, and basically what it does is it agonizes the sphingosine 1-phosphate receptor. I know all these things are very memorable in terms of their mechanisms, but unfortunately, it's just kind of the case. It's a lot easier to memorize like beta 1 receptors versus beta 2, but now we got the sphingosine 1 phosphate receptor. And so this one's pretty interesting because it actually helps to sequester lymphocytes into your lymph nodes and other lymphoid organs, basically, and prevents CNS penetration. So you can see different ways of trying to prevent the immune cells from getting to the actual neurons themselves and preventing that inflammation from occurring. So pretty interesting way to try to manage that. And as you could imagine, you'd also like to see you would see some lymphoma associated with that, which makes sense because all those cells are being sequestered in the lymphoid organs. But it is reversible once you stop the medication there. Of note, you'd also have this first dose bradycardia. So this is something where you'd want them to basically schedule out most of their day to come in, get their first dose in the office, for instance, and then you'd monitor them from 6 hours to make sure they didn't have any syncopal episodes, make sure the heart rate stays okay, make sure they don't need any atropine or something like that. And then again, if your immune cells are all kind of being sequestered in these organs, they're not going to be able to get out to fight other infections. So again, secondary infections are another thing you'd expect to see, and at least warn patients about, right? So another thing you'll find too is that there can be interactions between vaccines and some of these disease modifying therapies. We'll see this more prominently in the rheumatology section. But if you imagine like a vaccine requires your immune response in order to develop immunity against a certain pathogen, right? If your immune system is depressed for whatever reason, it does bring the possibility up that you may not be able to develop a good immune response to that, right? In some cases, or sort of the most common sort of adverse reaction as a result of this combination would be that the vaccine doesn't really work that well, right? So you don't really develop good immunity against it. The other thing that could happen, especially if you're dealing with what we call live vaccines, and we'll talk about this later in the immunology section, but live vaccines are basically weakened versions of the virus or the bacteria that you're dealing with, and we administer that so that way it does not cause disease, but you still get a good reaction against it. Well, if you have a suppressed immune system, there is a chance you could develop an actual infection with these viruses and bacteria, right? So that's why if you're dealing with something really immunosuppressive, and in this case here, Fengolamod, you want to make sure that, that they either get the live vaccine prior to starting the drug, right? Or 2 months after discontinuation. That way it makes sure that live vaccine does not activate and actually cause infection in that patient. This will come up over and over again in rheumatology, but this is kind of the first instance of it here. Okay, another drug here, we have Treflunamide. This actually inhibits this dihydroorate dehydrogenase, and it basically will help to prevent sort of proliferation of T and B cells, okay? If you could get to the point where you could just say, okay, I know Treflunamide prevents active or proliferation of T and B cells, that's good enough for me. I'm probably not going to get super, I'm not going to give you like, which one of these proteins does this drug inhibit, and give you like 4 of these like really obscure sort of names. Probably not going to get that sort of you know, nitpicky in terms of mechanisms, but if you can at least identify, okay, this sequesters T cells in the lymphoid organs, or this one prevents proliferation of the T, like that's kind of the stuff I want you to know, the functional actions of these drugs, not necessarily the specific proteins they're inhibiting, if that makes a sense there. We have questions, you can post them up, right? This is another orally available one, so that's good. And this is actually an active metabolite of the drug called Leflunomide. That's a drug we'll talk about when we get into rheumatoid arthritis a little bit later on, okay? Some drug interactions you want to be notable, or that is notable here, would be with warfarin. You can actually increase the INR about 25%, right? May not be a big deal if their goal is 2 to 3 and they're sitting at 2. May not be a big deal, but you definitely want to monitor it, at least check their INR. Other issues you can run into here includes things like hepatotoxicity, so definitely watch out for that. They can have some degree of hair loss, which is interesting, so it doesn't really seem to be related to its mechanism there, and some paresthesias. What is notable here is the teratogenicity with it, so this is actually pretty interesting. The drug itself undergoes what we call enterohepatic recirculation. This is something we've talked about before, where basically a drug will be eliminated through the biliary tract, out into the GI tract, and then at some point gets reabsorbed back into the systemic circulation. What that does is it extends the half-life of the drug pretty significantly. Estrogen does this, carbamazepine does this to it, carbamazepine does this, phenytoin does this to a degree. But the reason why I bring this up here specifically is because of the potential effects it could have on your patient, right? And in terms of the trajectory of their life potentially. you can find detectable levels of this drug for up to 2 years after discontinuation, right? So if you imagine if you have a patient who may want to get pregnant within the next 2 years, that would be something you definitely want to consider before administering this drug, right? Because, if they want to get pregnant, they could basically be on the sidelines for 2 years, right? To make sure that this drug would not affect their fetus. And what they'll actually recommend in some cases, they do want to get pregnant and they've not been on the medication for a period of time. They'll actually do what we call a cholestyramine washout. And if you recall, cholestyramine is a bile acid sequestrant. And so what this can actually do is it'll bind up the drug and basically allow it to being eliminated through the biliary tract, but prevents the reabsorption from the GI tract. So it interrupts the enterohepatic recirculation so that you can just defecate it out and then the drug is gone much more quickly. Okay, so that's one thing to note there. Another issue you're going to see, and this will come up with many rheumatologic drugs, is that you want to make sure that when you're active or administering some immunosuppressive drug like this, and this one in particular, to test for TB before starting therapy. Okay, probably going to be testing for that regardless if you're starting on heavy dose corticosteroids and all this other stuff. But the point being is that people can have a latent infection that once the immune system is suppressed can then activate, and then now they have TB on top of having their MS. Not an ideal situation. So always test them for that beforehand, at least with this drug in particular. All right, another one here, we have dimethyl fumarate. This is another one we don't really know the mechanism for how it works. We just know that it helps suppress some of that chronic inflammation we see there, and this is another orally available agent. Again, much better from a compliance standpoint. Patients don't have to come into an infusion center or inject themselves. They can just take it orally. Always a benefit there. Here you can see some lymphocytopenia, so you may want to monitor their CBC over time. Definitely monitor hepatic function, and then they can get some degree of flushing with this. I don't know if there's any particular way to try to mitigate that, but it is something that we do note. All right. Here's another monoclonal antibody. This is called Alumicizumab. This is another humanized antibody against CD52. This basically will, when you bind to that, what you're going to see here is that by binding to that CD52, it's actually going to cause this increased cytolysis, or basically it causes the breakdown of these T and B cells and macrophages and all the inflammatory cells that could be causing issues there in the CNS. And then what you're going to see with this one, actually, it is going to cause quite a bit of reactions when infused, like headache and rash and pyrexia and all of that. So a lot of flu-like symptoms you're going to see with this. So again, we can pre-treat for some of that stuff, right? So if I had a patient coming in receiving Alumicizumab, you could do things like give them Tylenol beforehand. You can give them Benadryl beforehand. In some cases, they may even get corticosteroids. So you'll see that for several different types of monoclonal antibodies you pre-treat to try to limit some of these infusion reactions there, so the patient has a little bit better time with it. This is another case here. By suppressing these immune cells, you're going to find that you'll have increased risk for infections. So that can include both respiratory, urinary tract. Again, we know that's going to be a problem, especially in elderly patients. If they have a history of herpes simplex virus, then they may need some prophylactic acyclovir because it could cause an activation, right? And then certainly you want to be checking for TB beforehand, right? Not only that, but they're at increased risk for developing the infection in the first place. Okay, one thing to note with that. And again, you can see why something like this would be not really preferred as opposed to something like, I don't know, Fengolamod, as an example, is the fact that you can actually develop some autoimmune disease from use of this drug. So this would not be something you want to use first line, probably hold off towards the end when nothing else is really working. Because even though you're treating an autoimmune condition, you can cause further autoimmune conditions to develop, including antibodies to attack your thyroid, pancreas, the kidneys, all of that. So you really want to be cautious before starting something like this, but kind of a unique side effect of this one. Okay, so here's kind of how you're going to use these. So you got that whole list of drugs there, and you're like, well, what do I do with this information, right? There's too many drugs here. Which one? They all sound bad to some degree. Which ones am I going to use? Basically, for patients who have sort of a poor prognostic factors, or maybe their clinical presentation becoming more severe, typically they're going to start off with something like natalizumab, Fengolamod, Treflunamide, dimethyl fumarate as what we call induction therapies, right? So they're inducing basically or trying to induce therapy to try to control those symptoms there. Even though it may have more side effects, the order is to kind of get things under control. And you're going to see that efficacy can vary pretty widely depending on the patient you're dealing with, and even at different times of their therapy, because this is going to be years long of therapy, that they can have different responses to these medications here. And so frequently, you want to look at things like, again, access to payment for these drugs, and also things like, well, what site of administration do you want to use? If you can get away with oral, that's obviously going to be preferred in a lot of cases, but they may have to require injectable products that they do less frequently, for example, right? But those four are probably the first ones you're probably going to go with in most cases there. The other ones may be used as sort of second and third line, if they start to fail some of those other four that were there, okay? And again, maybe not everyone gets started on disease modifying therapy right away. It just depends on how symptomatic and how severe they are when they first present with it. So let's talk about symptomatic management. This is something you're going to see quite frequently for many of these patients here. So to deal with a lot of the muscle issues that come along with MS, and this can include like spasticity, they can have issues with bladder issues, or they can cause incontinence to occur. Basically, we want to try to prevent these muscles from being kind of overly sensitive and overly hyperactive. And so we can do things like giving them muscle relaxants. I put two examples here. We're going to get more into muscle relaxants when we get into the ortho section later on. When I talk about pain management more specifically. But baclofen and cyclobenzaprine are two examples of muscle relaxants. Again, I'm probably going to be more specific about these in that section there. But we could also do things like gabapentin and pregabalin. So you'll see that used quite frequently for these patients. Again, good because they have relatively good side effect profiles and can help out with some of that increased spasticity. But in some cases, maybe that where they're more resistant to treatment with things like muscle relaxants, you could even use botulinum toxin, right? So Botox, basically. I probably mentioned this in times previous, and this will come up again in headaches a little bit later. But utilizing Botox is not just for aesthetic purposes, but can be utilized to basically help cause sort of a partial paralysis for some of these bigger muscle groups, and can allow for that spasticity to be relieved. Again, this would be something that would need to be done like in the office, or like, for instance, for our patients at Nemours, we do it in the surgery center. And then it does last quite a bit. So maybe, several months in between needing to get more Botox. If anyone's curious, I don't know if I mentioned it last time, probably just a broken record at this point, but Botox is actually one of the most potent toxins in the entire world in terms of the LD50 of that substance on a milligram per kilogram basis. It is the most potent toxin out there in the world, which is pretty wild when you think about it. People like to just like inject it into their face just for a good time. And there's actually, interestingly enough, not to go on a tangent, but I'll do so anyway. There was a case where I think it might have been a pharmacist, I think, who was at fault here, but they were trying to dilute Botox such that they were able to get more doses out of it than what they should have been able to, and it screwed up the dilution somehow and actually caused someone to die because the concentration was way too high, caused respiratory paralysis. So yeah, I always think it's funny when I'm like driving on the side of the road and I see those signs that say Botox, $10 a unit, come here. I'm just like, I don't know if I want to trust the most potent toxin in the world to be administered by people that advertise on the side of the road. I don't know. It seems a little fishy. So when I get my Botox, but if I were, I'd probably go to a more reputable site. Perhaps I'd rely on one of you if you guys go into derm to inject me. I'd trust you guys, someone off the side of the road, for sure. Anyway, for bladder issues, you're going to see here that we will typically try to utilize anticholinergics most frequently. We will talk more about this in the urology section, but basically by blocking cholinergic receptors on the bladder, it allows it to relax and you get better holding ability. The bladder kind of relaxes and just the filling volume can be higher. And in some cases may even need things like self-catheterization. So pretty frequently you see oxybutynin, but things like solifenacin, darafenacin will be used as well. We'll look at that more so when we get into urology later down in the semester. Yeah. Okay, so for some of the sensory symptoms you're getting, things like neuropathies and paresthesias and things like that, a lot of times we can actually get away with using our anti-epileptic drugs. So like carbamazepine has been used, phenytoin, and then also the tricyclic antidepressants. I'll get into those in much more detail in the behavioral section, so don't worry about that too much. I just know that TCAs like amitriptyline, imipramine, and things like that have been used to treat the sort of neurological symptoms of many of these conditions, right? So especially like fibromyalgia, neuropathies due to diabetes, things like that. You'll see these pop up again and again. So either anticonvulsants or your TCAs are done pretty frequently. We'll get into that later though. And then as far as fatigue, different things can be utilized here. So a lot of these will come up in the behavioral section. And again, this class is weird because I always have to restructure it based on your CMS courses. So I apologize for not having talked about these drugs already, but kind of the nature of the beast. But things like amantadine, which we did already see, talking about that in terms of its use for, I believe we talked about with Alzheimer's. And then antidepressants can be used here as well. Sometimes that will help out with their energy levels. So things like selective serotonin reuptake inhibitors. We'll get into that later. And then actually it's interesting as well. Some drugs you can use for different sleep conditions like modafinil or its enantiomer armodafinil may see used occasionally. If anyone's ever heard of the drug Provigil or Nuvigil, these are drugs that we will see used a lot of times for things like narcolepsy, or for patients who work like night shifts at jobs who have issues of sleep disturbances by basically their circadian rhythm totally being flipped on its head, basically because they sleep during the daytime and they work during the nighttime. So we'll talk about that later. It's called shift work disorder, I believe, or shift work sleep disorder. And then even amphetamines can be used. What couldn't amphetamines be good for, right? So you want to think about the drugs when we talk about ADHD. A lot of those are going to come up. So your Adderalls, Vyvanses, things like that, which we'll get into a little bit later on. As you imagine, amphetamines are stimulants, so that would definitely give anyone a little bit of boost to energy. Just like, I think, was it World War II that we used to give amphetamines to fighter pilots so they could be awake and alert for longer when they're flying their planes. Hopefully we don't have too much amphetamines used at big airlines, but you never know, right? Okay, so someone had a question. Someone says, is botulinum safe for people who are immunocompromised? Yeah, so Botox is not like an infectious sort of condition, right? So Botox is so you have Clostridium botulinum. Again, you're gonna get me on a tangent. I'm gonna nerd out here for a few minutes, but so Clostridium botulinum, while it is a bacteria, it actually produces this toxin, which is what can lead to paralysis, right? So if you ever think about someone who does like home canning of foods, if you ever see those cans that are popped out, it's probably because they got some Botox growing in there. Or for instance, with like, you never give infants honey because they could actually develop infantile botulism, because they can't deal with those spores that have the Botox there. So it's not really an immuno issue, because when we're giving Botox, we're just giving the toxin itself. So it's not like there's anything for your immune system to react to, because it's just the toxin. So in those cases there, it is not a problem for people with immunocompromisation. So you could have someone who's getting chemo, they want to get some Botox, not really going to be a problem for them. But that's a good question. I had not really thought about it that way before. Someone says, Paige is saying, can I use it to stay awake during PA school? If you are legally prescribed it by a physician, that's between you and them. I have no say one way or the other. Brian says, my uncle used to give me them so I could stay awake. Botulinum toxin or the amphetamines? That's the question, I guess. I'll leave that up to you guys to figure out. And then Shelby was saying, a pre-workout I used to take called Jacked was taken off the market because it apparently had amphetamines in it. Yeah, that's pretty interesting, because there are, if you look at like the actual amphetamine compounds, there's a ton of them. It's not just amphetamine and like MDMA, which is ecstasy. There's a gazillion of them out there. And so yeah, there's been some cases of pre-workouts being removed for having amphetamine derivatives in them. So yeah, I bet the workout was quite invigorating though, for sure. You did not fall asleep during that. Okay, so anyway, moving forward, let's talk about headaches real quick. Something I probably induced in you all quite frequently, if I were to guess. So we'll talk about migraines mostly, because that's kind of where we have the most new medications to talk about here. Certainly we'll talk about like medication overuse headaches. We'll talk about auras and things like that, which may pop up with migraines. And then real briefly, we'll talk about tension and cluster headaches as well in just a little bit. Someone was saying, someone says, for the caution about giving live vaccines to patients on Fengolamod, would that apply to all immunosuppressive drugs like corticosteroids? That is something I would be with corticosteroids, it's tough because the question is like, what kind of dose are they on, and how immunosuppressive is it really being? You know, certainly if they were like on a full like pulse dose, like they're having an exacerbation, I wouldn't mess with it then. But that can be kind of relative. There's certain drugs though that we'll find that it's just an absolute contraindication. You just don't want to do it. But with corticosteroids, it's really a matter of like the kind of dose they're on and how suppressive it's being, because it can range pretty greatly, as you'll see there. So, but not necessarily all immunosuppressive drugs. Some drugs are more immunosuppressive than others, right? So, like for instance, if someone was getting, let's say they were getting ifosfamide and vincristine and methotrexate for cancer, yeah, I would probably not want to give a live vaccine then, or really any vaccine, because again, you're going to find that if they're immunosuppressed, if it's a live vaccine, there's a chance you can get the actual infection. But other vaccines, which have no risk for causing infection, would be potentially less effective because you just don't have the immune system to respond to it to develop the immunity in the first place. That's a good question. Okay, so getting into our migraines. Again, what is a migraine? Well, there's probably is not fully elucidated yet, but there's some thoughts here, and this is kind of the predominant one we'll see, where basically we're going to find that something is happening to cause sort of this increase in blood flow in your CNS, where basically this increase in blood flow is causing increased pressure on certain nerves, especially like the trigeminal nerve. By causing that increased pressure, that causes inflammation, and then there you go, you got your migraine happening there. And you're going to see a treatment for migraine is actually pretty different than kind of routine headaches. And most people are probably going to know whether they suffer from migraines or they actually have just regular headaches, because migraines tend to be much more debilitating, much more painful than you might see for some headaches there, right? So, oh my goodness, look at all these goals here. So we're going to find that basically we have kind of two main phases for migraines, just like with many other conditions. We're going to have the acute treatment. This is going to be called abortive therapy. You may hear that term being used for migraine. So if they're having a migraine right now, how we treat that's going to be different than if they have kind of chronic migraines that we want to prevent kind of flare-ups of. Okay, so kind of more suppressive therapy. So we have long-term management, and then we're going to have goals for acute treatment thereof. And again, the drugs are going to be pretty different between the two here. Basically, though, you can kind of just try to distill these down as less migraines, less often. Try to deal with the symptoms they're experiencing. Try to, if they do have symptoms, get rid of them quicker. Try to help improve their quality of life, because I have I always remember, for instance, when I was in undergrad, I had this one RA in college, resident assistant, who when they had a migraine, they were shut down for like 2 days. They were basically don't knock on their door, because that was going to trigger their migraine. All the lights were off, blackout curtains on the windows. It was really miserable, and that always sticks out in my mind. So if we can do anything to hasten the resolution of that, or to decrease the number of times that happens, then that's going to be good. So that's kind of where we're going to go with this. So we'll look at our non-pharmacologic therapy briefly. We'll talk about OTC therapy, so over-the-counter stuff we can get, and then finally getting into our prescription therapy. That's where the new drugs we're going to talk about are going to come from. Certainly from a non-pharmacologic standpoint, a lot of things we can do here, which certainly are going to be used in conjunction with our medications, right? Kyle says, my mom gets bad migraines when she drinks alcohol. Had me convinced it would happen to me too for far too long. So you tempted the dragon and tried alcohol anyway. Interesting. Headaches are certainly a common thing you'll see, especially certain people, depending on the compounds in the alcohol that they ingest, not related to the ethanol itself, can actually cause headaches. So for instance, there's certain people who don't like to drink like certain red wines, or even wines from certain regions of the world, because they can actually trigger some of those headaches and migraines. Sulfites is certainly one of them, but I knew someone who I remember it was they were like, well, I only drink Chilean wine. I was like, well, fancy, la-ti-da. She's like, no, every other type of red wine would always give her headaches. So that's why it had to be Chilean in origin, which I thought was pretty interesting. I think more red wines, you're going to see that more frequently. I think whites are typically pretty a little bit more tame in terms of the additional components like tannins and stuff like that. Let's see. Kaylee's saying there's a strong genetic component in my family. My brother gets them to where he has an aura before and loses his peripheral vision. Eventually, he can't speak until it passes. Yeah, it's pretty intense. And actually, it can be helpful in some cases if you do have auras, because you can maybe start to initiate abortive therapy beforehand. So we'll talk about that a bit, getting into the medications in a little bit there. But yeah, so again, the alcohol stuff, it really depends on the patient. Now, of course, like hangovers, headaches associated with that are more often multifactorial, but frequently has to do with things like dehydration. Just like basically you were just like drained of most of your fluids due to the diuretic effect of alcohol, and that can be a big challenge for them. So I always tell patients, make sure you play the water game, because otherwise you may develop a hangover. But it's neither here nor there. So certainly, if you can avoid triggers, so like for instance, if you know certain red wines are going to cause you to have a migraine, maybe don't drink those red wines. And of course, sleep, rest, exercise, all that good stuff is going to be helpful to help mitigate the number of reactions they can have here. And again, these are common food triggers. These are going to be not the same for everyone, but it just really depends. So for instance, like MSG for some people can cause migraines, which you find in a lot of Asian food and things like that. Caffeine withdrawal. Interestingly enough, caffeine is a treatment for headaches. We saw for the pathophysiology for migraines that it was caused by some of that vasodilation, causing pressure on those nerves. Caffeine itself is a vasoconstrictor, and that's going to kind of be in line with some of the other treatments we're going to see for migraines. But certainly having caffeine withdrawal can cause kind of rebound dilation of those vessels and lead to quite a few headaches there. Yeah, you need an IV bag of caffeine. We could do that. They have it at in the NICU. We have IV caffeine. We administer those little babies. But yeah, I'm pretty sure my tolerance levels for caffeine are at a point now where if I had any cessation of use, my head would explode, I would imagine. But again, this is not about me, right? It's about our patients. But even things like tyramine containing foods, we talked about that a bit with the monoamine oxidase B inhibitors back with Parkinson's disease. Again, those foods that are high in tyramines, those are sort of precursors to a lot of those catecholamines and can induce headaches. So remember those aged cheeses and aged meats, red wines, pickled food, things like that. Those kind of those bougie foods that I talked about. You can refer back to that list. And then certainly environmental triggers like high altitude, loud noises, strong smells, any of that kind of stuff can certainly trigger these. And again, we'll talk about strong smells and stuff when we get into like pregnancy later on. I always find that stuff interesting. People's sense of smell can be acutely altered by physiologic conditions. But getting into the pharmacologic therapy, again, this can either be for acute treatment or for preventative treatment. And what's interesting is that a lot of the preventative treatment, if sort of used incorrectly, can induce headaches and migraines. That's kind of a double-edged sword there we're going to look at later on. And then we really need to be treating these symptoms based on how they're presenting, and also looking at kind of the frequency and duration of headaches, what they've been using at home, right? So what they've already treated themselves with is important. So, find out, okay, well, when you get these headaches, what do you normally do? What have you already taken? When did you take it? And that can influence what you're going to do for them sort of in the acute phase, as we'll see. So, generally speaking, we want to administer medications at the onset of the headache, or if they have an aura preceding it, like you mentioned, Kaylee, if we can administer it earlier with the aura and before the symptoms happen, that can be useful, right? That can be useful for some patients there. And then we're going to find that the medications themselves don't treat any of those neurologic symptoms, things like the aura, but they will help to manage the pain and help with the resolution a little bit faster there. And we generally, as we're going to find, is that a lot of these drugs are vasoconstrictive in nature. We don't want to overuse them because there has been cases of things like medication overuse headache, where medications actually tend to make the headaches worse. We'll have cases where a stroke has been caused before by some of these medications, causing relative ischemia due to vasoconstriction to the CNS. So the goal is for them to use their abortive therapy as little as possible. And if they need it, they need, therapy more often than that. Try to get them on something preventative, right? Okay, so for acute treatment of these migraines, and again, I think about this from the ER setting, but you could certainly see this from, in the clinics or urgent care, things like that. But think about like the other kind of ancillary symptoms patients are having here. It's not just the headache itself, but in the pain they're experiencing, but it's also a lot of like the nausea, vomiting associated with this as well. So you want to make sure you're getting treatment for that additionally. Okay, so looking at mild to moderate migraines, typically going with NSAIDs, Acetaminophen generally is going to be ineffective by itself, but if you did something like ibuprofen plus acetaminophen, that may be able to get some benefit, right? So kind of utilizing some synergy there. And again, because that makes sense, looking at the pathophysiology, remember that there's inflammation going on, causing a lot of that pain. So ibuprofen, good for inflammation. Tylenol, not really, right? And then for patients coming into, and they may be trying that at home, right? And then when they come in to the clinical setting, that's where we want to think about things like parenteral NSAIDs like Toradol. That's going to be kind of your bread and butter for a lot of these patients here, right? Give them some Toradol. That way it is, able to help out with that inflammation really fast acting. And again, consider if I had a patient who says, I used ibuprofen 30 minutes ago, I may be less likely to jump to Toradol than if they were like, it was a few hours ago, right? So maybe I took my ibuprofen 4 hours ago. Okay, jump to your Toradol, but that's why I like to ask patients, what have you already tried to use for this particular headache? And that can guide what I'm going to use going forward. Okay. Generally, opioids don't really have a role in the management of migraines unless they have failed everything else, or if you have a generally maybe opioid happy practitioner. But again, there's a lot of restrictions on that stuff, so that's becoming less and less frequent. From a nausea vomiting standpoint, this is where generally things like Zofran, totally fine to use, especially because it comes as a sublingual tablet, so you don't have to worry about them swallowing anything. But you tend to find certain people will respond better to certain ones than others. So, for instance, like promethazine or Phenergan suppositories may be available if they don't want to do anything orally. Reglan, prochlorperazine. I find a lot of practitioners do like compazine for migraines in particular. They find that it works better for them anecdotally. So, I have no problem with that. Compazine kind of fits in the same category as our phenothiazines. And again, we'll talk about those extensively in the behavioral section coming up. So any of these are fine. Ask what the patient has used before and what works for them. If they say, Zofran doesn't even touch it, I just still vomit everywhere, then try something like the phenothiazines. They tend to be more sedating, but for some people having a migraine, taking a nap is not necessarily a bad idea, right? They probably want to have some shut-eye anyway. So again, figure out kind of what the patient condition is and what's going to be most appropriate based on the side effects. My uncle used to give me promethazine suppository so I could stay asleep. Brian H. That's one way to keep a kid asleep, for sure. I would not recommend that for routine use. But like I mentioned, I had a brief experience with promethazine, and it certainly gave me a very long, restful sleep. So again, everyone's going to respond differently to it. You guys are really selling each other out up the river here a little bit there. It's interesting. Anyway, and again, so the I'm going to see a quote here. I myself, Peter Trabolsky, just murdered somebody. So try not to sell each other up the river too bad, right? Oh, geez. Anyway, so talking about, you guys got me on a tangent here, but so remember that, when you have patients who are having this severe nausea vomiting, think about administering nausea medication along with some of your other abortive therapies, right? So you need to go hand in hand. And frequently, say for instance, you are writing, if you have like an order set available to you. Okay, now I'm gonna think about Rick and Morty this whole time. Hopefully I don't have any burps like Rick does. But you're gonna find that when you're doing these order sets, you'll have those options available to you, right? So you'll pick, okay, abortive therapy, hit this drug, then you're gonna have, NSAIDs, so you hit Toradol, and then you'll have your drugs for nausea vomiting. You'll click off on whatever one you want to use, whether promethazine or whatever. So those will be organized for you that way in a lot of cases when you're working there. We already talked about the GI section, so sometimes this comes before GI. But anyway, so now we want to get into some of the new medications for more moderate to severe migraines. This is where our ergots are coming back up again. We talked about bromocriptine back in Parkinson's treatment as a dopamine agonist. Ergots are going to come and have a big role to play here as well. And basically what these are going to do for us is we're not so concerned about its dopamine activity, but we want it for its 5-HT1D and 1B activity. Basically, by activating 5-HT1D and 1B, you're going to cause vasoconstriction of those vessels up in the CNS, and that's going to lead to, hopefully, cessation of your migraine, right? Also, you can find as well that some presynaptic activation of these receptors, the serotonin receptors, will cause a decrease in things like peptides like substance P that causes pain, and some mediators from inflammation and vasodilation. So basically, this is going to cause constriction of those vessels. It'll relieve the pressure off that trigeminal nerve and hopefully deal with the pain that the patient is experiencing. And this makes sense, right? We talked about St. Anthony's fire before, but remember they complained about, burning sensation and gangrene even in the toes and the fingers. So that vasoconstrictive property, we're now using it for the CNS purposes in order to help manage these migraines. So a couple of varieties here. We have ergotamine tartrate, and then we have dihydroergotamine. So if you hear ergot in the name, you can think, okay, that's a fungus. I know that's an ergot derivative. That's what we're using it for. If you ever hear DHE, that is referring to dihydroergotamine, okay? Note it here, too, that we have different dosage forms available to us, so things like nasal sprays, suppositories, because, again, a lot of these patients are going to be nauseous. They're not going to want to take oral medications, right? Okay, so I'm going to say, let's see here. Someone said if a patient comes in with a bad headache and took 800 milligrams of ibuprofen 1 hour before with no relief, what's your next choice? So at that point, I would probably consider trying out some acetaminophen, if that is reasonable. So say they're just having a headache. You could try acetaminophen to see if that's going to provide any relief, since it's only been an hour since they got the ibuprofen. If that's still not working and everything else is, maybe it's been another hour or so, you could try Toradol. I don't think you're going to necessarily... No one's going to develop an ulcer off of that, just 2 doses of NSAIDs. But, you do increase your risk for GI upset if you were to, kind of stack those NSAIDs on top of one another. So that would be one thing I'd be watchful for. Certainly I'd avoid opioids if at all possible. But again, look at why they're having the headache. What's going on that's causing that? Is it a true migraine? In which case, one of these abortive therapies is going to be necessary. Or, something else is going on. We'll look at some of those examples there. Good question. It seems like good TQ. If you don't know what TQ is, that's okay. Let's see here. So, as I mentioned, by activating those receptors, you're preventing that pressure and the activation of the trigeminal nerves here. A good thing about the ergots, test question. Yeah, that's a... Now, see, that would be tough too if I asked a test question like that, because there's kind of a bit of gray area there. Now, certainly an opioid would be like a bad option, and that would be like a good distractor. But yeah, so if I ask test questions, I will make sure to be very clear and explicit about what the right answer is going to be. Otherwise, it's not a very good test question. Don't have enough history. Yeah, I might actually put in some additional stuff on there. Like, so for instance, I could put, patient is pregnant, or patient has a history of liver disease. So maybe you don't want to give them Tylenol, right? Little things like that you may want to think of. Anyway, good. And we'll talk about this in the review tomorrow. So don't worry yourself too much yet. Now with the ergots, the benefit here is they do have a nice long half-life. So this helps to make sure that, if they come into the ER, you treat them for the migraine there, but you may find for shorter acting drugs, they will have headaches that recur later on, right? And so by having a long half-life, this helps to prevent that, those recurrences down the road, hours to a day later, right? However, we're going to find that there are some side effects associated with these. And again, this is why you got to ask questions, because if the patient already uses an ergot at home, do not want to use another dose when they come into the clinic or the urgent care or ER, wherever they're at, right? Because you can run into a lot of these side effects from having too much vasoconstriction. How that can manifest is pretty wide, as we're going to see here. So things like hypertension, they can develop chest tightness, nausea, vomiting associated with this. These drugs in particular, the ergots, cause a lot of nausea, vomiting. So you definitely have to treat for that. Even if the patient wasn't nauseous beforehand, I would just go ahead and give them something because I do know it's going to cause a lot of nausea, vomiting. The big thing I'm concerned about as well is going to be this thing called ergotism, right? So ergotism makes sense based off of the names of the drugs. You can link those two together. But this is peripheral ischemia, meaning you're basically giving your patient St. Anthony's fire, so to speak, by causing these kind of cold, numb, painful extremities. So all those really distal small vessels are now being constricted, which can lead to paresthesias. You can see gangrenous extremities. Now, this is rare that you would run into that, but if a patient was using too much at home and then they got another dose in the ER, you could see how that can stack up on itself. The other things you could also potentially see would be ischemia to other vessels or to other organs, like the heart or the brain, things like that. Even like mesenteric ischemia has been noted. Again, that line is rare, but could still happen and make sense based off of the mechanism of the drug there, right? So who do I not want to use this in? So basically, anyone who has a history of vascular coronary disease, if they have hypertension that's not currently well managed. So say, if they have hypertension and they come in and they have a really good regimen on board and their blood pressure's, 110/70, they could probably get an ergot. Probably not going to be a big deal for just that one dose of the drug. They come in and they're like 160 over 95, I'm probably not going to want to give that person an ergot. Then the increase in blood pressure is not going to be worth it there. This is another one that's going to be contraindicated to category X for pregnancy, so do not give this to pregnant patients. And again, typically, who do you think about as being more likely to have migraines? Oftentimes it's women, right? So again, you want to worry about things like pregnancy. If you're going to administer this, I'd probably want to make sure that patient's not pregnant. So that could be something you want to consider there too, right? And then you also want to worry about things like impaired renal or hepatic function because, again, having that extra vasoconstriction on top of that may worsen function there, okay? And we'll see that if patients have used a triptan within 24 hours, which triptan is another category of drugs we'll talk about in a moment here, do not use these two together. Again, way too much vasoconstriction, too big a risk for side effects, okay? So now we get into the triptans. These are going to be basically also 5-HT1D and 1B agonists, so kind of similar mechanism to the ergots. We're going to see these are a lot more specific just for the serotonin receptor, and so you're going to see probably less side effects overall than the ergots. But sometimes you have patients who, even though these drugs are first line nowadays, you'll have some patients that say, "Nope, triptans don't work for me. Imitrex doesn't work. You got to go with the DHE. That's just what works for them, right?" So it can depend on the patient there. Again, a lot of these you're going to note will have different dosage forms available to them. So, for instance, like sub-Q nasal spray, that's important. If the patient's nauseous and they're not able to tolerate anything orally. So, I'm not going to ask you which ones come as a nasal spray, but again, that's why it's important. It's why we have those alternative dosage forms. Now, the first one we had here is sumatriptan or Imitrex, and this one was what we kind of consider to be the first generation of triptans and was a really big deal when it came out because for the longest time we just had really ergots that we were using in order to treat these migraines. And so this was the first one that came out that has got a better safety profile, even though we're going to see that you're going to have some cases here where there's some additional benefits of using later ones due to things like the bioavailability of the drug. You can see here it's pretty poor for sumatriptan as an example here. However, this can vary depending on the drug that we're dealing with. Sometimes even gender, as you can see, may have an effect on the bioavailability of the drug itself. So we'll get into that. Again, percentages I don't care that you know necessarily. I'll talk about some points that I do care that you know coming forward here in a little bit. See, Jackson saying my sibling was administered Imitrex IV on accident. I've seen cases of it being administered IV as ordered. So hopefully nothing bad happened, but if that was something I'd be concerned a medical error had occurred. Certainly would want to monitor the blood pressure and things, but hopefully everything went okay there. I would not be as concerned if like something else was given IV on accident, like epi or something like that. But anyway, so you can tell it's a triptan because we'll have triptan in the name. So sumatriptan, olmatriptan, rizatriptan, naratriptan, almatriptan, frovatriptan, and then elatriptan. Let's see. Order sub-Q, everything was fine. They just gave a ton of fluid. Yeah, that could be another thing too. And again, when you're dealing with patients like this coming in for headaches and migraines and stuff, you'll be amazed at how good a liter of fluid is going to make someone feel, right? Especially if they're, say you're working out at the beach or something, they come in after having a heavy night of partying, complaining of migraine, as a result of maybe ethanol use, a liter of fluid really goes a long way. So that will certainly be something you want to consider administering to these patients in addition to nausea medication and some of these abortive therapies here, right? Anyway, so looking at this, as I mentioned, they have similar vasoconstrictor properties as the ergots by their activating the same serotonin 1D and 1B receptors there. So the mechanism is not really all that different than what we're going to see. However, big differences are going to be in terms of the kinetics between the drugs. So as an example, with the ergots, they had a nice long half-life, so we didn't really have to worry about people having recurrence of migraines later on. However, like something like sumatriptan, which is kind of our first triptan that we had there, about 40% of people are going to have recurrence that same day. So they'll be fine in the ER. You send them home, and then they're calling back complaining of another migraine, right? So that's one thing we're going to try to get around that by using drugs that have longer half-lives, things like frovatriptan or Emerge, which I believe is rizatriptan. Naratriptan, I apologize. The one that has a long half-life, right? So anyway, what we can expect to see is going to be similar to the ergots, probably to a lesser degree overall though, but you can still see things like chest tightness and pressure. Certainly can see things like increases in blood pressure associated with this. Occasionally get some paresthesias, but not nearly to the same degree as the ergots, right? So who do I not want to give this to? Pretty similar to what we saw with the patients with ergots. Again, they have a history of coronary artery disease, angina, MI, history of stroke or other CVD, peripheral vascular disease, anything like that. Definitely not want to mess around with that, okay? Notice pregnancy is not on this list. So pregnancy is not going to be an absolute contraindication for the triptans like they would be for the ergots. So that's one kind of key difference here. The other thing too is that you want to be careful messing around with patients on monoamine oxidase inhibitors, like selegiline, like we saw before in Parkinson's, and then some of the drugs that we use to treat depression. We use those very rarely to treat depression nowadays. But the thing here is that by using an MAOI that decreases metabolism of serotonin. So now you have a drug that activates serotonin receptors on top of more serotonin. You can see some serotonergic toxicity, which we'll talk more about in the behavioral section later on. And again, do not use this within 24 hours of ergots. So ergots and triptans together are a no-go within 24 hours, okay? So how do we choose triptan? Well, basically, sumatriptan is probably gold standard for most patients starting out, just because it's relatively cheap and available for most patients. And again, you have a couple different dosage forms you can use there. In terms of onset of action, you're going to find that parenteral typically is going to kick in faster than what you're going to see with intranasal or PO forms, right? And if your patients have a migraine right now, tell them, hey, you got to wait an extra hour because you took the PO form may not be ideal. So, maybe them getting a shot sub-Q may be an okay trade-off for them if they're having an actual migraine right now. But recall, sumatriptan has a relatively short half-life, so you're going to get a lot of recurrence here. So what we do to get around this is to use a second-generation drugs that have maybe decreased headache recurrence due to longer half-life. They'll have better bioavailability, especially if given orally, and hopefully decreasing the adverse effects like those chest symptoms and chest tightness that we talked about before. And they overall are going to have better CNS penetration by being more lipophilic and better bioavailability, longer half-life, right? So again, I'm not going to ask you specifically which ones are going to have ODTs available versus nasal sprays. Just have an idea of why we would use those alternative dosage forms, because these patients are going to be nauseous most likely and having vomiting associated with that, right? Note that naratriptan has good bioavailability and a long half-life, so that's going to be good for patients who have a history of, say, recurrence with sumatriptan, right? So then, hey, I took Imitrex, but I always get a rebound or get another headache a couple hours later. Something like naratriptan might be a good option for them, right? And again, which ones are covered by their patient's insurance may be variable, so that can also make a difference in terms of which ones you pick there as well, okay? Rizatriptan is actually an interesting one here. There's actually a big drug interaction with a drug that we're going to use for prevention of migraines, and that's propranolol. So we'll mention that a little bit later on, but you can actually see a 70% increase in the area under the curve or overall exposure to the drug that could lead to a lot of those hypertensive sort of symptoms there. And so if we were to use rizatriptan plus propranolol, you'd want to decrease the rizatriptan dose in order to avoid having that really big jump in the side effects you'd experience with that, okay? So rizatriptan propranolol, it's a pretty unique interaction there. If they're on propranolol already for prevention of migraines, lower the rizatriptan dose, okay? This one does have a pretty fast onset, so that could be additional benefit if they were needing some fast onset of action. See, almatriptan, this one is metabolized by CYP3A4, so there could be some interactions there, and also has the highest bioavailability, so interesting from that standpoint. It overall has a pretty decent ADR profile compared to something like sumatriptan, so some people might like that one. And then frovatriptan is notable because it has the longest half-life, like 24 hours. So this would have pretty similar activity to naratriptan, probably a little bit lower of a recurrence rate than something like naratriptan might. So those are kind of the big things. And again, it's just a matter of finding out what's going to work best for your particular patient. So some of it may just be luck of the draw if they respond well to a drug or not. Really just depends there. Again, make sure that if they're having nausea, vomiting, picking a non-oral route, either sublingual or sub-Q, intranasal, something like that, and be aware that sub-Q is going to work faster than intranasal or PO, okay? About an hour for sub-Q, more like 2 hours for intranasal and PO dosage forms, okay? And typically, we're going to be utilizing these for patients who are kind of resistant to other treatments. So if they know NSAIDs don't work for them, Tylenol is probably not going to work for them. This is where I can get into using the triptans. Okay, and most people are going to start with a triptan first, and if that's not really being effective for them, then they may try an ergot instead. Okay, or it could be provider preference, I suppose. As I mentioned, do not use triptans within 24 hours of ergot use or other triptans because you can get that really prolonged excessive vasospasm. Could lead to MI, stroke potentially, hypertension for sure. So I want to be careful with that. And then typically try to avoid using more than 2 days per week of abortive therapy. If that is the case, then we probably need to look into some sort of preventative sort of agent here, right? You can kind of go through this in terms of a flow sheet or flow chart for how you'd want to utilize these drugs here. Again, patient education is super important here. Looking at the overall severity of the headache or any kind of like associated disability, and then consider what you're going to be treating there. So what kind of dosage forms are most appropriate? Do I need antiemetic therapy, etc.? Definitely for more mild to moderate cases here, I would definitely consider using our analgesics, as we mentioned here, and then utilizing, in some cases, caffeine may work for patients. Mentioned that briefly, how that can be used as a sort of vasoconstrictor there. But if they're not getting adequate symptoms here or adequate relief from these, or they're already starting off with severe symptoms, that's where you want to go either triptans or ergotamines. I'd probably go triptans more often than not. And if that still fails, then utilizing something like an ergot as an alternative potentially. If they're still having severe symptoms and nothing's working for them, then you may consider something like an opioid, but that's exceedingly rare that we have to go all the way down that road. Okay. Let's see here. Someone said, why is sumatriptan gold standard if the second gen triptans seem like much better options? Well, because that was the first one out on the market. And so I think that's what people had most experience and comfort with. And then, you'd see that that just was, due to force and momentum, that's what people are using the most often. As the new ones come out, they're generally more expensive. People don't have as much experience with them, and so they may even have lack of knowledge of them. And again, there's not one clear-cut winner out of that second generation bunch on which one's going to be most effective. So just from a cost standpoint, nowadays, sumatriptan is probably the go-to, right? If you look at most ERs, what they have on formulary, you'll probably see sumatriptans on that list because the other ones are generally more expensive. And sumatriptan works for most people, so it just depends on the patient there. Someone said, would you put more than one triptan as an answer choice on the test? Yeah, I could ask something like, which one of these triptans has the longest half-life, right? Or which one of these would have that? See, that would be a very basic way to ask the question, which one has the longest half-life. I could also ask it to where, which one of these would have the lowest chance of recurrence of migraine after initial use? Then you'd have to be able to kind of make that logical leap saying, okay, well, why would they have lower recurrence with one agent or another? Oh, wait, I know, because half-life will affect that. If it has a long half-life, then there's less likely to be recurrence, right? That could be one thing to consider differentiating one triptan versus another. So one thing to consider. That is an example of when you might have more than one triptan on a test question. Okay. Switching back over here, let's talk about medication overuse headaches. So a little bit of smattering of things here. This is where patients are utilizing either over-the-counter drugs, opioids, triptans, ergots, using it more than 15 days per month, or with our kind of heavier duty drugs like the ergots or triptans, more than 10 days per month. Okay. What you're going to find is they tend to get sort of the sensitivity where their headaches are just getting worse, even though they may be using drugs every single day. And so best thing to do for medication overuse headache is to try to wean them off of the drugs and try to help them discontinue if possible. Typically, you're going to find that this will resolve after about 2 months or so after discontinuation. So some of them may need to kind of wean off things a little bit to avoid rebound headaches. But yeah, so you can find patients that are over-medicating, and that's going to lead to just worsened headaches for them. Okay. In terms of treatment here, if it's using between 7 to 12 analgesic tabs or capsules per day, you could probably abruptly discontinue, or if you wanted to, taper over 4 to 6 weeks or so. And then that's when we're going to talk about using prophylaxis meds. I'll talk about those at length coming up here in a moment. Usually withdrawal periods last about a few days to weeks. And then if they're on more than 12 analgesic tabs or caps a day, or if they're pregnant, I would not abruptly discontinue anything, but I would try to find a way to gently wean them off of that, probably closer to that 4 to 6 week period there. Okay, so looking at preventative therapy, who would I want to pick for preventative therapy? Well, probably people are having a lot of recurrent migraines, especially if it's starting to interfere with their daily lives. If they can't go to work or they're calling out of work, or perhaps they couldn't sit through their pharmacology lecture, even though they're really looking forward to it because they have such a bad migraine, those might be people you want to consider utilizing preventative therapy for, right? Or perhaps if they were contraindicated from some of the other therapies, right? Maybe they couldn't use anything due to pregnancy or something like that, adverse drug reactions to other therapies, things like that. All reasons why you may consider using preventative therapies here, right? Typically, beta blockers are going to be your go-to, okay? These are going to be effective by 80% of people as first-line therapy. So propranolol is classically used kind of as a go-to just because it has high lipophilicity and thus is able to get into the CNS quite easily. That's probably why I see this used most frequently. But really, any of the beta blockers could be utilized. So if they had a history of asthma, for instance, then, atenolol might be a good option for them, or metoprolol would be reasonable as well, okay? Now, the thing to consider with these agents, how they're working is basically by preventing that vasodilation from occurring in the first place, right? But if you think about it, beta blockers are, they're antihypertensive. They'll lower your blood pressure, and that probably includes some degree of vasodilation. So if you start full blast beta blockers in these patients, it's very likely you're going to cause a large amount of vasodilation and induce a migraine, right? That's the double-edged sword I talked about earlier. So by starting out kind of low dose and going low and slow, you're able to basically try to prevent that vasodilation as opposed to causing a big, massive round of it. And that should be able to prevent the migraines from occurring, right? Basically helping out with some of that those dynamic changes that occur, those vessels that lead to those migraines. It kind of helps to normalize things a little bit and prevents that dilation from occurring. There's probably some effects to do with platelets as well, but the main thing is to block the vasodilation. More often, and nowadays you're starting to see more frequently, especially if patients don't have any like concomitant cardiac history, they may be put on an anticonvulsant as a first line for preventative therapy. So as an example here, using something like a valproic acid derivative. So valproic acid, divalproics, any of those that are in the same sort of family tend to work. But recall, you probably don't want to use valproic acid in pregnant patients because it's teratogenic and cause neural tube defects if you forgot that. So that would be a case where we want to be really careful, make sure patients are not going to be at risk for becoming pregnant. And then Topamax, I am seeing to some degree, remember it has kind of a wide number of different activities there, slowly kind of becoming first line depending on the provider and depending on comorbid conditions and whatnot, but pretty well tolerated if anything. You're going to find the side effect profile is very not causing as much sedation as valproic acid or as a beta blocker as compared to these other agents. So that's probably why Topamax is getting used pretty often here. In terms of other things we could use, antidepressants, we'll use these sparingly, but we'll talk about them more so in the behavioral section, but it can include your tricyclic drugs, your SSRIs. Overall, they're trying to affect the blood vessels by preventing reuptake of serotonin and norepinephrine to some degree. And so you're going to find that helps to kind of keep the blood vessels from having that dilation occurring in the first place. It just normalizes things, kind of like what we saw with the beta blockers there. And then calcium channel blockers are used occasionally. This is going to be mostly like verapamil is frequently used here. You'll see this sometimes used for patients who have aura associated with migraines. It can be effective. And then nifedipine is used occasionally. Again, think about the same drug interactions you want to watch out for, things like CYP3A4 inhibition by verapamil affecting other drugs, things like that. And some patients, they actually have issues where, like, especially like the muscles in the back of the neck can lead to their migraines occurring there, and things like botulinum toxin can be used for those particular types. So you can actually pick out those individual muscles, kind of pull on the back of the skull and paralyze those to some degree, and that will help prevent migraines. So really depending on the patient, what the kind of etiology of their migraines are in the first place. Overall, start low and go slow. You'll find a lot of these, if you kind of go full blast like verapamil or propranolol, you can induce a migraine. So that's where you want to be cautious there, and give it about 2 to 3 months or so to see how effective they're going to be. And then if they're getting some benefit, you can consider trying to wean them off of it. Perhaps they've gotten to a point where they're less likely to have migraines. Just really depends. And then just look out for drug interactions like we talked about before. Okay. So you can see here some reasons why I might pick one of these agents over another. So for instance, if they, if they're having, let me see, as an example, hypertension or angina, right? Maybe a beta blocker or verapamil might be a good option for them, right? Because you can get dual benefit from that. If they have depression, well, maybe something like a TCA might be able to have a good option there. So this could be like a really good source for questions I could ask saying, okay, a patient has migraines, a history of epilepsy. What's a good preventative drug? Well, probably an anticonvulsant, something like valproic acid, right? If they say they have depression, maybe a TCA or an SSRI would be good there. So those are kind of questions I could ask based off of that. And again, there's not one clear first line option for every single patient. A lot of it is based off comorbid conditions, right? Someone said, could you explain again how propranolol inhibits vasodilation? Is it a different mechanism of action in the brain versus the heart? I might have missed something. So think about it in terms of, why do blood vessels dilate? What are some of those things that can affect that? And so if you recall, beta 2 receptors tend to be vasodilatory. So, and again, beta blockers, of course, are working through other mechanisms like blocking renin and things like that. But one of the things you'll see by blocking a beta 2 receptor, you're going to find that it will block some of that vasodilation that occurs by blocking beta 2 receptors from being activated, basically. And so if you think about someone with migraines, they could have a case where their vessels are very dynamic. They could go dilated, constricted, dilated, constricted. The point of the propranolol is to try to help mitigate some of that dynamism, I guess, and try to make sure that it kind of stabilizes it and tries to keep the dilation at a certain level such that it cannot have a large amount of dilation all of a sudden that causes the migraine to occur. So it kind of just keeps things a little bit more steady to prevent that dilation. And verapamil is doing the same thing, and I apologize for slapping my mic. But verapamil will do the same thing, basically, by helping to kind of mitigate a lot of the, how the volatility in that vessel in terms of causing dilation from occurring. Hopefully that makes sense. All right. So as I mentioned, migraines, let's see, Peter's saying, I apologize for derailing the lecture before to Brian in the class. That was poor taste. Oh, no, don't worry about it. No, we're fine. No, I'll be fine reading the chat. If I was really offended, I'd probably take it offline, but you guys are all right. No, anyway, so getting into migraines in women, and trust me, you guys, this is a safe space here. I want you guys to feel comfortable and I like our joking atmosphere to some degree. May get a little bit too much for some people, but that's okay. That's what reviews are for at the end of the semester. Anyway, so with migraines, you'll see there, higher prevalence in women to some degree. In some of this, you're going to find in terms of different things that can affect this. So certainly around certain areas of like menstruation, you may find they may be more likely to have a migraine, or contraceptive use can affect this too to some degree. So you can find that sometimes being put on OCPs may help a patient's migraines, may worsen them in some cases. Pregnancy may be a new cause for it. And then, pregnancy being the source of a whole lot of extra hormones, and then menopause being the retraction of those hormones, you can find that it really is dependent. So for some patients, giving them hormones is the key to helping out with migraines, can help to mitigate that. For some people, that is the exact opposite of what you want to do. We'll talk more about this when we get into OB-GYN section later on, and we'll talk all about hormones and the menstrual cycle and ovulation, all that fun stuff there. But in terms of menstrual migraines themselves, the one thing you can say for these at least is that they're predictable, right? So most women are on about a 28-day cycle, and you can find in some cases that some of this may be due to the estrogen decreases that happen, right? So there's a normal cycle for estrogen, how it kind of ebbs and flows throughout the 28-day cycle. And when you have that kind of crash of a decrease in estrogen, sometimes that's when you can develop these menstrual migraines. And so for some people, you can find that, NSAIDs may be good, triptans might be good for treating that, but sometimes estrogen may be the answer for them. So being on OCP may be decent. You'd actually continue that for like a 5 to 7 day period in some cases. Again, that's going to be much more sort of unique to the individual patient. It's probably not going to be like your first line treatment for the majority of them. It'd be something you'd have to learn over the course of treating them for, say, months to years potentially, right? Let's see. Oh, here we go. Someone says, Fioricet effective in treating acute migraines or more so for severe headaches? Ask me because I saw this used frequently in the ER. Okay, I dislike Fioricet and Fiorinol. So what is Fioricet and Fiorinol? So basically it's a combination of a couple of different drugs. So maybe I should write this out so that way it's a little bit more clear for you guys. Let me see here. Word. Oh, good. You can see that. Good. Okay. So, a couple of different drugs here. We're going to have Fior set, and then you have Fior and all. I don't talk about very much, mainly because I don't like the drugs. I might have it on a slide coming up, but just so I can break it out here. So this usually contains a combination of caffeine, This one will also have caffeine. This will have a barbiturate called butalbital. This one will also have butalbital. And then the big difference here is if you're a set, we'll have acetaminophen. That's how I remember the difference. Acetaminophen, set. And then fiorinol will actually have aspirin in it. So these are non-controlled substances, but they still contain a barbiturate. So one interesting thing is that if you have a patient who's taking this, they will actually test positive on a urine drug screen for barbiturates. And so because barbiturates, at least, this isn't the 70s anymore, but nowadays you don't see a lot of abuse of barbiturates. So I'll have providers will be like, well, this patient's taking barbiturates. What are they abusing phenobarbital or something? And most of the time you just ask them if they're taking Furoset, and they'll be like, yeah, I take Furoset. And that's what's causing it. I tend to find that this is a common source for kind of misuse or overuse and for treatment of headaches. And again, remember, it has Tylenol in it, right? Or has aspirin in it, which are drugs that can have their own issues if dosed too frequently or too aggressively. I tend to find that overall, it's not super effective for treatment as compared to some of the other agents that we've already been talking about here. So I'll get more into that. I think I have it coming up in just a moment here. Oops, I don't want to get rid of myself. I want to get rid of that. Let me talk about that more in just a second. Okay. Since I'm not sure if I misheard, you shouldn't give hormones to people who have migraines due to hormone reasons. No, I'm saying that it depends on the patient. So for people who have really routine, or not routine, but I should say predictable migraines based around the menstrual cycle, some of that may be related to estrogen decreases. So by giving them hormones, you could fix that problem. For other people, though, you may find that migraine intensity or frequency is increased by giving them things like oral contraceptives. We'll talk about that briefly as we get into the OB-GYN section later on. But again, it's very dependent on the patients and what they're going to respond best to. So I wish I had a better answer for that. That's kind of what it is. Okay, so getting back into this. So... And as I mentioned with oral contraceptive use, again, they can promote, change, or relieve migraine. Most women, though, experience no change whatsoever. So, again, it could be the third option, is that nothing changes at all. Frequently, you're going to find if that oral contraceptives are causing or increasing migraines, one thing you can do is to try to use either a different formulation or maybe decrease the dose of the estrogen they're receiving. You could try a progestin-only compound. So we're going to see there's some drawbacks to that. We'll see later on. Some people may benefit from having something like an IUD in place. In some cases, actually, vitamin B6 has helped, which is kind of interesting. Another case you could do is to either discontinue the oral contraceptive and in place for something like an IUD, or actually what's interesting is decreasing the number of estrogen withdrawals. So most people think about OCPs as being like, 21 days of active drug, then you have 7 days of withdrawal, and then you start the cycle all over again. There's some where you only have, 4 periods in a year, right? Or you may only have 1 period in a year. So it's really interesting how we can change the menstrual cycle in kind of schedule period, so to speak. And I'll get more into that a little bit later on in the OB-GYN section. It's pretty wild stuff you can do with a person's body utilizing hormones. In terms of migraines in pregnancy, probably acetaminophen is going to be the most reasonable drug to use in the majority of cases here. It's going to be kind of the safest one we have available to us. In terms of alternatives, ergots are going to be category X. We definitely don't want to use that. NSAIDs are going to be category D in the 3rd trimester, which means you definitely want to avoid them. Earlier on, you could use them, though. So if a pregnant patient in their 3rd month of pregnancy got a dose of ibuprofen, probably not going to cause a problem. The triptans are in this category called category C, which I'll talk about later on in the OB-GYN section, but basically category C is kind of like, we're not really sure, or we don't have enough evidence to say whether it's safe or harmful. So you can still use it occasionally. And then very occasional use of opioids may be required. Ideally, though, if we could try to utilize non-pharmacologic means, that's going to be great, especially from a preventative standpoint. So that's kind of going to be the goal there. Now, the rest of the headaches here are going to be nothing new that we're going to see. As I mentioned, Furoset and Fiorinol, I did have a slide here so you can kind of see the differences. I've seen a lot of cases of people using it too frequently, leading to a lot of rebound headaches, and in some clinical trials, this only has been as effective as placebo, so not great, but it's something that I do see prescribed a lot. I see a lot of patients on it, not necessarily to great effect, but for the most part, I try to utilize just OTC remedies like acetaminophen or NSAIDs, right? Excedrin usually has some caffeine in it. In terms of prevention, you can utilize things like your TCAs or SSRIs, or in some cases, smoking cessation can be treated with this, right? Bupropion or using some kind of nicotine alternative may be beneficial. For cluster headaches, nothing big here besides utilizing, these are really, really painful headaches. Ergots have been used to some benefit here along with triptans, and there may be some cases for oxygen to be beneficial in helping to sort of clear these headaches more quickly. So nothing too novel there. We do find that for cluster headaches, verapamil tends to be pretty effective. And then some other ones we can use occasionally include like lithium. Probably wouldn't want to use chronic ergots due to risk for hypertension and things like that. And then corticosteroids have been used occasionally, but I would not use this for long-term therapy. Again, so just some options you have available. Most likely though for cluster headaches for prevention, I would go with verapamil in most cases. So that is it. I finished a few minutes early. See if I have questions. Someone said, is the estrogen withdrawal causing a headache similar to caffeine withdrawal causing a headache? You could probably think about the two the same to some degree. I would say I don't know the exact mechanism for estrogen withdrawal causing headache, but it's probably something a little similar. Caffeine, though, is much more vasoconstrictive than estrogen necessarily is, so I don't know. Okay, well, so that's it for this section. I do have to run, so I'm probably going to hop off right about now. But if you have questions, save them for tomorrow. We have our review, so we'll be on Zoom, and I cannot wait to see you all then. So thank you very much for your time, and I will see you tomorrow. I'm going to hop off real quick.